So, we all know what anemia is, we all know that it can be isolated or appear like a syndrome with other systems and organs alterations, and that's not always, it's not always PAX6 and WAGR syndrome. We've also seen that we can find genetic alterations at a chromosome level, DNA level with deletions, duplications, or in the nucleotide sequence. The main gene we know is PAX6 with point mutations or deletions, some duplications too, but there are other genes involved in aniridia and aniridia-like cases. And all of this is very important to take into account when we are performing the genetic analysis. So depending on the technique, we can detect different kind of mutations or alterations at a chromosome or single nucleotide level. But in these days, with the new technologies, we are getting there to detect everything with one technique. So why did I go through all these things that to a point we already know? Because they are basic for genetic counseling. And why do we want to do genetic counseling, and why do we want to test patients, apart from research and learning about this gene and this disease? Because many times it's important to confirm the clinical diagnosis, and the segmental dysgenesis is not always easy to diagnose correctly clinically, because we need to know whether there's a risk of Wilms tumor. It's also important for the patient to know the prognosis and the measurement that the child or the elderly or the old person will need. It's important for knowing the reproductive risk, not just for the patient, but for the rest of the family and parents, to avoid transmission, if that's what the patient wants, and for future perspectives to know, like treatment or future knowledge. So for genetics assessment, and in aniridia it's very important, the age of the patient is not the same. A child that's just born that an adult patient that has a parent that's affected with aniridia, we all know that. The age of the parents, that has a lot to do with reproductive options. The type of mutation or pathogenic variant that we have identified, not identified, and the technical feasibility for detecting that variant, whether it's a novel inherited or whether it's isolated or syndromic. So, as general, we all know that aniridia is an autosomal dominant disorder. So, and therefore, an affected patient has a 50% risk of transmitting it to his or her descendants. So, we know the mutation from the genetic counseling side of things. We can do a reproductive assessment, and we have reproductive options. I will go through them afterwards. When we don't know the mutation, we still can do many things. We can still assess regarding the risk, and there's still reproductive options, and the patient still has the option of going into research projects in order to unravel where the mutation is. For the novel cases, well, for the patients, it's as the familial cases, 55% risk. But what for the parents? We all say it's low risk. We know it's the literature says always 5% in this kind of situation. But and then that for the family, the rest of the family, they have the population risk, because for genetic diseases we know that risk is never zero. So, important also to point out that for the novel patients, mainly their children, it's a basic thing. The first thing that we must do is rule out WT1 deletion for the Wilms tumor risk, and we know that if there's no deletion, no risk for this tumor, and if there's a deletion, we need to follow up the patient. So, for the patient, we can do, again, reproductive, when we don't know the mutation, again, there's still things to be done. We can assess, and there's reproductive options, and we can always look deeper in the research of the mutation. And when we know the mutation, it's the same as for familial cases. But what about the parents? Well, we've all have read recent papers about mosaic genes in parents with children with aniridia, which is kind of quite important because it's not the same when we don't detect mosaicism and that when we detect mosaicism in facts of risk. So it's important for their options because if there's mosaicism, the risk is higher than if there's no mosaicism. And also in the novel cases, it's a bit apart. We have found a dilation affecting the 11p13 region. Although we don't generally perform it so much anymore, but karyotyping is still important because we have to rule out whether there might be a balanced rearrangement involving chromosome 11 that would increase the risk of the recurrence risk for future pregnancies. So, what tests we are doing? Well, we're beginning to perform tests on the degree of mosaicisms on these different tissues, or embryonic tissues, or imaging tissues, sorry, to try to assess recurrence risk. This is not available on routine basis, but hopefully it will be in a short time. So going to the reproductive options for these patients, when the mutation is known, we will have the classical prenatal diagnosis, which is amniocentesis or chorionic biopsy. And what we do is take cells from the amniotic fluid or from the chorionic villi, and we perform parallel karyotyping and DNA studies. And DNA studies depend on the mutation in the family, of course. If we're looking for a deletion, we probably perform an array. If we're looking for a polymerization, we will perform sample. And what about non-invasive prenatal diagnosis? Well, we all know that when a pregnant woman have fetal DNA around in her blood, it's around, represents about 5% of the DNA. And we can test for the mutation in the family if it's paternal or de novo, so if the mom doesn't have it. And these tests have to be designed at home. So that means that they have to be designed for each couple, each patient, each mutation. So it requires a lot of work, and it's not possible in some cases. We've been performing this kind of study since 2005, and we've performed around 70 cases already, including cases of aniridia. And we hope that in a short future we will be able to test for maternal mutations and all type of mutations as whole genome sequencing is getting into routine practice more and more. The other reproductive option I mentioned before, it's professional genetic diagnosis. So this is a process that requires a number of steps and criteria to be able to access it. In Spain, it's in the national health system, so patients with aniridia and a known mutation can ask for this kind of treatment. So when a patient asking for this gets to our clinic, we always have to assess how the process is, whether it's possible or not, the risks and benefits, and the rates of success, which are not always as expected by the patient, and always we have to discuss alternative options. Of course, all genetic processes involve informed consent, and in the case of PGD, there are some inclusion and exclusion criteria, which are genetic, legal, and gynecological and urological, that have to be met in order to go through this process. So genetic criteria would be genetic indication, that's technically feasible. Again, not all mutation can be tested by PGD. We was confirmed, sorry by the mistake. So we have to know the mutation, and we have the informativity studies that are basic in this technique currently. Then there's legal criteria that depend on the country. So in Spain, it has to be a severe pathology, early onset, and without a curative treatment. So for aniridia, it fulfills criteria for PGD. And there has to be also gynecological and andrological criteria, which means that I have to be fertile. So PGD is based on assisted reproduction, IVF, which or ICSI, or ICSI, sorry. So IVF, it's in vitro fertilization, and ICSI, it's intracytoplasmatic injection of sperm. Both techniques, what they want is to generate embryos, and once we get the embryos, then we can perform an embryo biopsy in order to perform the genetic test. Ahead of doing the reproduction treatment, we always go through testing for genetic markers that allows to determine which is the copy of the gene that carries the mutation, which are called informative studies, and generally performed with haplotypes, whether with STRs or point variants that make us different. So we perform the biopsy. That can be done on day 3, and now they're beginning to be done on day 5 because we have access to more cells, which improves the quality of DNA that we can study, and therefore more studies can be performed. And as you see, we get a number of embryos with different combinations of the parental chromosomes, copies of the gene, and we determine which ones are free of mutations and which ones are not, and therefore are affected. So these are examples of the studies that we perform in order to determine the affected embryos or healthy embryos. So, oops. That's a bit what we do. We get the cell, we do the study of DNA. We can see the marker. These are SDRs, so the informativity studies, and we also do a direct study of the mutation when it's a point mutation. So when we've got an embryo that we know it's free from the disease, we can transfer it to the female for, close our fingers, having a pregnancy. When we have a number of embryos and we cannot transfer all of them, generally it's not anymore, we vitrify them in order to keep them for further cycles. This is the process in our hospital. They have to fulfill some information in our web. Then they have a consultation with our gynecologist and with genetics when we discuss options and whether it's feasible or not. If they fulfill legal criteria or criteria, we will perform the informativity studies and we'll begin the
Fiona.
cycle. Okay. And so far we have performed nearly 1,000 PGDs in our center, and including of course aniridia, and we are the center for PGD in Madrid in the national health system. And that's our rates. So as you see, 40% newborns. Okay, so it's not the best thing, but it's an option. And thank you to everyone, to my colleagues at the hospital, research and clinical, and to the patients and the associations. Thanks.